Hello, everyone, and welcome to the third and final webinar in our Navigating Brain Health and Dementia series. I'm Dr. Sandra Fryhofer, trustee of the American Medical Association, and it's a pleasure to be with you today and lead this important discussion. This series is brought to you by the American Medical Association in collaboration with the CDC and the Alzheimer's Association. Our first webinar was all about screening and diagnosis of dementia and featured Dr. Rachel Whitmer and Dr. Barack Gaster. Our second session focused on risk reduction for Alzheimer's and related dementias, things you can do now to reduce risk of developing it. It featured Dr. Cynthia Carlson and Dr. Kate Curley. If you are unable to join us for either of these first two sessions, you can watch and listen to them using the link shared in the chat. This third session focuses on treatment of Alzheimer's and related dementias. Studies consistently show being proactive in managing Alzheimer's and other dementias can improve quality of life for both the individuals affected and their caregivers. These proactive strategies include managing coexisting conditions, coordinating care among physicians, providing caregiver training and support, participating in activities meaningful to the individual with dementia, as well as appropriate use of available treatments. Today's discussion will cover three issues: clinical treatment approaches for dementia, care delivery for patients with dementia, including the GUIDE model, and also pharmacologic approaches for treating dementia. And we're joined today by three outstanding experts in dementia treatment and care delivery: Dr. Oscar Lopez, Dr. David Rueben, and Dr. Stephen Salloway. Here's the plan. Each of our panelists will give a short presentation, then we'll move on to questions from our audience. Many of you already submitted questions when you registered, but if you didn't submit a question early, no worries. You can still add your question to the chat, and we'll try to get to as many of those as we can. Okay, let's get started. We'll begin with clinical treatment approaches for dementia. Our first guest, Dr. Oscar Lopez. Dr. Lopez is professor of neurology, psychiatry, and clinical and translational sciences at the University of Pittsburgh Medical Center. He's the Levido Pittsburgh Foundation Endowed Chair in Alzheimer's disease and dementia disorders. He's also chief of the Cognitive and Behavioral Neurology Division and director of the Alzheimer's Disease Research Center at the University of Pittsburgh. Dr. Lopez's primary research is focused on distribution, incidence, and prevalence of behavioral symptoms, as well as risk and long-term outcomes of dementia, including Alzheimer's disease. Dr. Lopez has conducted large-scale studies on the clinical diagnosis of Alzheimer's disease and vascular dementia. He's led many studies on refining clinical criteria for Alzheimer's disease and other dementias. He's also been both principal investigator and co-investigator of studies looking at factors that modulate the transition from normal to mild cognitive impairment to dementia, and the relationship of that transition to cerebral amyloid deposition. Please welcome Dr. Oscar Lopez.
Thank you, Sandy, and thank you for having me here. Next slide. Next slide. So, dementia is very, very common in people age 65 and older, and the prevalence and incidence is very high, and is similar in practically every country around the world. So the global number of people with dementia will increase from 50 in 2019 to 152 million in 2015. There is someone is diagnosed with dementia every 3 seconds. And we estimate that we have about 6.9 million Americans aged 65 and older with Alzheimer's disease. So we have a big challenge in front of us, trying to find the right treatment for all these patients. Next. So what are the risk factors? The only risk factor that we know for sure is age. Then we have sort of a genetic component, which is the APOE4 allele that increases the risk. It's in about 20% of the population. And there are some other possible risk factors, especially cerebrovascular disease. And then there are some things that we can do not to protect us, but just to decrease the risk. And there are many publications that show that moderate alcohol intake, Mediterranean diet, physical activity, and cognitive activity can decrease the risk. It doesn't mean that if you do that, you are off the hook. It means that you decrease the risk, so things may happen later. Next. So Alzheimer's disease is a neurodegenerative process, and neurodegeneration means loss of neurons. And you can see on the left with a green background in dark, those are neurons in early stages of Alzheimer's disease, and then you can see in the other square, the late stage. Why we are losing those neurons? Which one is the initial process that triggered the pathology of Alzheimer's disease? We don't know. So neurons are dying, but we know there are some pathological markers that are associated to this process of neuronal death. One is the amyloid deposition. And you can see that we have now technology that can detect the amyloid in the brain. Neurofibrillary tangles, that same thing, and inflammation. And all these things can be now identified with PET technology, but also with blood tests. Next. So when is the best time to intervene in patients with dementia? We think that the best treatment is primary prevention, is when the pathology is not there and the people are cognitively normal. Secondary prevention is when some symptoms start to emerge and the pathology start to emerge. And then after that, we have all the symptoms of dementia. But the right time will be primary prevention is when the disease is not there and symptoms are not there. Next. So this is all the drugs that we have or medications for Alzheimer's disease. It's interesting. The first one was Tagrin in 1993. So this happened 30 years ago. And then between 2003 and 2021, we have a huge gap in medications coming to the market. And it's not because we were not doing anything. It's because the trials were not very successful. So, but now in 2021, we have aducanumab, then lecanemab, and donanemab, and we expect approval by the FDA of donanemab this year. So that's why I put the question mark. But so we start having medications that can modify the disease process. Next. So, and this is a figure that shows all the trials that we have, and the field has never been so crowded. And this is really, really important. It shows a great deal of activity in researchers and in scientists that are trying to find medications for Alzheimer's disease. This is for 2022. The 2023 was published recently. But again, it shows the same thing. It shows a huge number of treatments that we are trying to test to treat Alzheimer's disease. Next. This is another type of intervention. This is there are many studies and there are many programs that they use very intensive interventions with nutrition, exercise, cognitive stimulation, and cardiovascular treatments. And this is from this is the FINGER study, was done in Finland, that shows how people that participated of this study had better cognitive functions than those who were not doing anything, and they did not have the benefit of this intervention. Next. again, this is, I was talking about that what happened between 2003 and 2021. And these are large-scale studies, and you can see when it says NS is not statistically significant, There were many failures, but we learned a lot. We learned that the interventions have to be done at very early stages. And then when we start moving in that direction, you can start seeing some good results with lecanemab, donanemab, and aducanumab. There was one trial was positive, one was negative. But you can see, for example, with in the lecanemab trial, the CDR sum of boxes, the people treated had 20% less decline than the untreated group. So these are significant advances in the treatment of Alzheimer's disease. But it took a long time to learn this. Next slide. And this is the importance of the anti-amyloid drugs. As I remember, I showed you a figure with the amyloid plaque and how we look at the amyloid, how can we identify the amyloid plaque using PET scans. And all these drugs, especially the donanemab and lecanemab, can reduce significantly the amount of amyloid in the brain with a clinical effect. Next. So we are entering in a new era of Alzheimer's disease treatment. More anti-amyloid treatments are coming. The implementation of these treatments is not easy, so it requires well-trained personnel. We are now seeing the increased role of blood and imaging biomarkers. There are going to be a combination of treatments. So we will expect to see anti-amyloid drugs with anti-tau drugs. In the combination of those two drugs, those two type of treatments will be in the market. We can say that there are many people working very hard for this to happen. And the traditional medications like cholinesterase inhibitors and memantine, they will remain as symptomatic treatments for Alzheimer's disease. And this is my last slide. Thank you.
Well, thank you, Dr. Lopez, for sharing your expertise with us. We're now going to shift our focus to care delivery for patients with dementia, including the GUIDE model. On July 31st, 2023, CMS, the Center for Medicare and Medicaid Services, announced a new voluntary nationwide model called GUIDE, the Guiding and Improved Dementia Experience Model. The GUIDE model focuses on dementia care management. Its goal is improving quality of life for people living with dementia, reducing strain on their caregivers, and enabling people living with dementia to remain in their homes and in their communities. For this discussion, we turn to our second guest, Dr. David Rueben. Dr. Rueben is a professor of medicine at the David Geffen School of Medicine, director of the multi-campus program in geriatrics medicine and gerontology, and chief of the Division of Geriatrics at UCLA, the University of California, Los Angeles Center for Health Sciences. And that's not all. He's the Archstone Foundation Chair, Director of Alzheimer's and Dementia Care Program at UCLA, and Program Director of the UCLA CMS Guide Program. Dr. Rueben still sees patients and is attending physician on the inpatient geriatrics unit. He also continues to provide primary care for older persons, including making house calls. And Dr. Rueben, we're glad you made a house call with us today. Please welcome Dr. Rueben.
Thank you so much. So we're going to talk mostly about GUIDE here, but in the question and the answers, other aspects of dementia care, I'm more than happy to answer. Next slide, please. Okay, and Dr. Lopez covered some of this, but just to expand upon what he said, is that Alzheimer's disease in particular is a disease of aging. And whereas if you're 65 to 69, the likelihood is about 3.5%. 75 to 79, this approximates the overall average of about 10%. But By age 90, about 35% of people will have dementia. And being among one of the 70 million baby boomers, we will all begin to turn 90 in 2036, not that far along. So if you think about that, either yourself, your brother, or your sister, one of the three is likely to have dementia, Alzheimer's dementia, by the time they turn 90. A higher prevalence in African Americans and those who have lower high school education. Next slide, please. So here's the problem. Not only is dementia a lousy disease, it's a terrible disease, the quality of care for dementia is not good. And these are ACO PCPI quality measures. So if somebody fails a screen, only a quarter of them are getting a cognitive evaluation. Medications that might contribute, only 9% are reviewed for that. Caregiver support, only 29% of people who have dementia, their caregivers are given support. And this is largely a women's issue. 61% of caregivers are women. Monitoring for behavioral and psychological symptoms, fewer than half. And there are poor linkages to community-based organizations. Next slide. The consequences. So not only is this a bad and devastating disease, it's an expensive disease. $345 billion last year for healthcare, 3 times the number of hospital stays, higher provider, nursing home, home health, and drug costs. And that doesn't include the caregivers. 11 million caregivers providing 17 billion hours worth $340 billion. And this table is very nice. Everything is very symmetric here, is that if you have dementia, it's roughly 3 times more expensive, whether Medicare is paying, Medicaid is paying, out of pocket, and total costs. So very expensive. Next slide, please. Okay, Dr. Fryhofer just mentioned this. The July 31st announcement of this, it was a big deal. It was a huge deal. They had this webinar and the Director of Health and Human Services came on and they had terrible technical issues, so to the half hour getting delayed. But they announced it, and they announced it in the context, this is the first time Medicare has ever done anything for caregivers. And we'll talk more about that in just a moment. Next slide, please. Okay, so how are they going to do this? First of all, to define a standardized approach to dementia care delivery. And there are 9 components that are required. We'll get into that a little bit later. Second of all, providing an alternative payment methodology. We're going to go into how people are paid for this, but this is new money coming in to care for persons with dementia. Addressing unpaid caregiver needs by caregiver training, support services, 24/7 access to support, as well as connections to community-based organizations. Respite services. Payment for respite services temporary. They can be provided in the home. In other words, a home care agency sending caregivers out to somebody's house, an adult daycare center, or sometimes at nursing facilities that can provide 24 overnight care for patients. And finally, something I think they really got right was screening for health-related social needs and helping healthcare systems navigate to community-based organizations to try to better address these. Next slide, please. Okay, some nomenclature here. So guide model participants are not patients. Guide model participants are healthcare organizations. Specifically, they're Medicare Part B providers and suppliers. They have to have an interdisciplinary team, including a care navigator who's received at least 20 hours of training, and a clinician with dementia proficiency. And these can be I think all three of the folks who are on the panel today, designation neurology, psychiatry, geriatric psychiatry, behavioral neurology, and geriatric neurology. There are some other areas kind of that you can earn to be proficient in dementia care as well. 2 tracks. Okay. Tracks, established program, those are programs that have already been providing this kind of care in 6 out of the 9 domains for at least a year. And today is a big day. Today is Guide's birthday. And it's not its second or third birthday, it's its birthday. So as of today, July 1st, 2024, Guide is in existence. The second track are new program tracks, and those are programs that haven't been providing comprehensive dementia care for a year, and they get a year ramp-up period. And that begins today as well, with the idea that they would start getting paid for services in July 2025. Excellent. Now here are the patients, the beneficiaries. So they have to have a diagnosis of dementia. This is not a program for people with mild cognitive impairment. Medicare has to be their primary payer, and they have to be enrolled in Part A and Part B, but cannot be enrolled in Medicare Advantage or the special need programs or PACE. Okay, so this is to augment Medicare Part A and B. We can talk about this in the discussion section. The not enrolled in hospice, because hospice provides many of these benefits, and not residing in a long-term nursing home. And that's because there's less, I think, that they feel that this program can benefit these people. Next slide, please. Payment. All right, this is new. It's a per beneficiary per month payment. So if you are enrolled in Guide, if your patient is enrolled in Guide, your healthcare organization will receive a monthly payment in addition to whatever is billed for fee-for-service Medicare. The amount per beneficiary, there are 5 categories, and they're based on mild, moderate, or severe dementia, and whether you have a caregiver or don't have a caregiver. There will also be adjustments based on health equity and performance standards. And here is one of the very exciting things is this respite care payment. So all patients, beneficiaries who have moderate or severe dementia will receive an annual cap. This is essentially a bank account for them to spend for emergencies when you need an in-home caregiver or to go to adult daycare. This will be covered up to $2,500. This money is not awarded to the patient themselves. It goes to the participant who spends it and keeps it. It's basically a bank account for them. And then for those underserved populations, there is a one-time lump sum for development of new programs at $75,000. Next slide, please. Unfinished business. All right, this is an 8-year demonstration program. So it begins today. And you can enroll new patients through the first 7 years, and the last year it's just following these people. And they have an external evaluator. But the results of the demonstration project are probably not going to be available, the main findings, for a decade, just to be honest with you. And the other unfinished business is, how they're going to determine whether this should be converted to a permanent benefit. Right now, it is a demonstration. But the biggest unfinished business is who's not in Guide. So you have this wonderful program. There's dozens, I suspect over 50 organizations that are going to be Guide participants. But who's not in Guide? And first of all, the biggest are the Medicare Advantage patients. More than 50% of beneficiaries are now enrolled in Medicare Advantage programs, and they are not included. Special needs plans, PACE enrollees, hospice enrollees, and then beneficiaries who are not cared for by GUIDE programs. A number of the applicants were not accepted into GUIDE, and even more just couldn't get it together or didn't have the motivation to apply to GUIDE. So there is still a lot of unfinished business, but this is a huge step forward and demonstrating that in principle this can be done and can be paid for, and hopefully a benefit for all at some point. So I think that's my last slide.
Well, Dr. Rueben, thanks so much for sharing the details of this fabulous program, and thank you for your leadership and your insights. Our final presentation will focus on pharmacologic approaches to dementia treatment. Although current medications cannot cure Alzheimer's, FDA has now approved 2 categories of medications: drugs that change disease progression for people living with early Alzheimer's by removing beta amyloid from the brain, and drugs that temporarily mitigate symptoms of Alzheimer's dementia. Our third presenter, Dr. Stephen Salloway, will now share more about pharmacologic approaches for dementia treatment. Dr. Salloway is an internationally recognized leader in clinical trials for the prevention and treatment of Alzheimer's disease. He's professor of neurology and psychiatry in the Department of Psychiatry and Human Behavior at the Warren Alpert Medical School at Brown University. He's also associate director of the Brown Center for Alzheimer's Disease Research and founding director of the Memory and Aging Program at Butler Hospital. Dr. Salloway has been a lead author of key publications for Alzheimer's biomarkers and treatment research. He's an expert in amyloid-related imaging abnormalities and their management. He's also a member of the Alzheimer's disease and related disorders therapeutic work group. This work group develops appropriate use recommendations to safely guide the clinical use of new disease-modifying treatments. Please welcome Dr. Stephen Salloway.
Well, thank you, Sandy, for including me, and it's great to be on the program with Oscar and David. I'm going to focus my remarks about the new amyloid-lowering antibodies in clinical practice. Next slide. So we have, as Oscar mentioned, we have treatments that have some clinical benefit. They're approved for the dementia stage of Alzheimer's disease. And we use them, and we've been using them for more than 20 years now. But the disease progresses and people still die primarily of Alzheimer's disease or its complications. And we've been looking for treatments, as Oscar mentioned, for many years to try to modify and slow down the disease process to add to medicines like donepezil or memantine. Next slide. We took heart from the original work from Dale Schenk and others that show that transgenic mice who build up amyloid pathology could have substantial lowering of the amyloid plaques by being immunized against a form of A beta and then developing antibodies to clear it. That research went into clinical trials, into human trials quickly from the mice. The initial studies cause encephalitis in a small subset, and so they had to be abandoned. Those active vaccine strategies are still being pursued, but the focus has really moved toward monoclonal antibodies that are administered exogenously that bind to amyloid plaques that lower them. Next slide. So we've tested a number of strategies in the amyloid pathway. We were hoping to find secretase inhibitors, either beta or gamma secretase inhibitors, and we have agents that can inhibit those enzymes and reduce plaque buildup. And they're oral agents, and we thought they might be able to be used widely and early in the disease process. However, so far, those have actually made memory worse slightly, and it appears reversibly, but they have not moved forward into clinical practice. Where we've had the most traction, and Oscar mentioned recently, is with amyloid-lowering antibodies that are immunotherapy. They're monoclonal antibodies against A-beta. Next slide. These medicines, there are three that are currently, well, two that are approved and one that's near approval, the donanemab. They get into the brain at low concentrations. Currently, they're given intravenously, and they bind to amyloid plaques. They stimulate microglia to help break up the plaque and lower it. Lecanemab is the first antibody to receive full approval, and that was last year, based on one phase 3 trial in patients with early Alzheimer's disease. And as Oscar mentioned, we discovered that patients with later stages of dementia so far had not responded well to this treatment. And also we had difficulty lowering amyloid sufficiently to really see a clinical benefit. So the trials have now been focusing on, the ones that have received approval are focusing on people with mild cognitive impairment or mild dementia due to Alzheimer's disease. So one advance that Oscar referred to is that we learned that once amyloid PET became available, we could screen for amyloid pathology, which we're targeting with these treatments, because previously a substantial portion of the patients were not building up amyloid plaques. But now we can confirm that prior to treating patients. And we're going to be doing this in the clinic as well. So in one phase 3 trial of lecanemab in patients with a mini mental state score of 22 to 30 with a positive amyloid test, studied for 18 months, next slide, against placebo, there was clear amyloid lowering and a slowing down of cognitive decline. So this does, even though it removes amyloid substantially, and the majority of patients move from becoming amyloid positive at the beginning of the trial to amyloid negative at the end of the trial, what we would consider amyloid negative, below the cutoff, consistent with Alzheimer's disease. We have not reversed the disease process clinically, but we've slowed it down at the group level. Obviously, some patients do better than others, but there is a clinically meaningful slowing of clinical decline. Next slide. Donanemab is another antibody that's very good at lowering amyloid plaques. And this study was a little bit different. They had some innovations in it, also for mild cognitive impairment and mild dementia. But the patients now with mini mental was 20 to 28. The amyloid level was a little higher than the lecanemab trial. So patients were a little more clinically impaired, also had a little more, their biomarkers were a little more advanced. And that study required tau PET, that there had to be at least a moderate to high level of tau PET, thinking that those patients would be most likely, with intermediate tau PET would be the ideal target, who were not too far along in the disease process. They could still have amyloid lowering and receive a clinical benefit. So that was the key focus of the treatment there. And in that study also, unlike lecanemab, had a stopping rule. There was a follow-up amyloid PET scan, and when the amyloid level became negative, the medicine was stopped, and the patients were followed without treatment. And lecanemab, it's open-ended at the moment. Next slide. And that study also showed substantial amyloid lowering with a slowing down. Really the best data, these are not head-to-head trials, but the best data we've seen so far in slowing down of clinical decline on cognition and daily functioning. Now, this is a modest benefit. I want to be clear. This does not stop the disease, does not reverse the disease, but it's our first step in targeting a key component of the pathology and slowing it down clinically. Next slide. And the most meaningful, to me, the most meaningful clinical outcome is in the movement of the patients as a group from one level of dementia, from MCI to mild dementia, or from mild dementia to moderate dementia, And that's substantially slowed with both of these treatments, with lecanemab and donanemab. And that's meaningful to patients. And that's what we tell them, that the goal of treatment is to try to slow down the disease process so people can stay in a milder stage of Alzheimer's with better quality of life and independence longer. And we don't have an exact time frame here, but we're talking about at least 6 months time period of slowing, and that people want that. They really, David showed you what the level of fear is about Alzheimer's and dementia, and it's the later stages that people are afraid of. Next slide. And it looks like so far the degree of amyloid lowering is important. So these are different antibody programs that target amyloid plaque, and all of them lower it. But the ones with the greatest lowering, and these are lecanemab and donanemab, have had the best clinical benefit. So there needs to be substantial, at least so far, we need further research, substantial amyloid lowering to see the clinical benefit. And I think that's one of the reasons. There were two main reasons why we didn't have success earlier with this strategy. One, patients were more impaired, more advanced in their dementia. And two, we didn't have enough amyloid lowering at that time. Next slide. Now, safety, like with any new treatment, safety is critical, and you have to weigh risks and benefits. So that's very important. Our job as clinicians treating patients with Alzheimer's disease, for these treatments especially, are selecting the right patients, making sure they're a good candidate, knowing how to monitor for safety, and I'm going to go into this a little bit, and then also having very frank discussions with patients and families about risks and benefits to make sure, if they are a good candidate, that it really is favorable to them and they decide they're willing to accept the risks associated with it. The main side effects can be infusion reactions, and they're actually fairly common with lecanemab. They're fairly easily managed. They occur early on with treatment. They're allergic type reactions, hypersensitivity reactions. But the site, the infusion center, and the team needs to be prepared to manage those. The most important side effect is called amyloid-related imaging abnormalities. This is a drug-induced side effect where there can be fluid shifts, edema, microhemorrhages, and even macrohemorrhages in the brain. That's a physiologic effect, and more pronounced and more inflammatory in some patients than others. In the majority of cases, when this occurs, there are no symptoms. But the changes, the edema or the microhemorrhage shows up on MRI, and we need careful review of the baseline MRI and then ongoing safety monitoring with MRI, especially during the first 6 months of treatment. Symptoms can occur, and it's important to pay attention to those. And there are nonspecific headache, dizziness, unsteadiness, confusion, and visual disturbance. But there can be more serious inflammatory cases, and which can be fatal. So it's very important to, next slide, and this is what ARIA looks like. This is on the left side, you see edema. There can be edema into the parenchyma of the brain, into the hemisphere. There can be edema into a sulcus. It can be subtle. It can be severe. It's quite wide-ranging. There also can be hemorrhagic changes, the most common being microhemorrhage, which shows up on a heme-based sequence on MRI. Sometimes the hemorrhage lies in the sulcus, in the meninges, and that's called superficial siderosis. These are very important markers of cerebral amyloid, and can be an important marker of cerebral amyloid angiopathy, and are very important in evaluating prior to starting treatment. Next slide. Yeah, so the main risk factors for ARIA are the number of copies of ApoE4, the dose of the drug, and underlying cerebral amyloid angiopathy. Next slide. And this just shows you that ApoE4 plays a big role in ARIA frequency and also risk of more serious ARIA. So this is an innovation. We need to test for the ApoE genotype prior to treating people, so the patients are aware of their risks and potential benefits, and also the clinician can monitor more carefully for safety. Next slide. So as I said, it's really important to have very frank risk-benefit discussions with patients and families. It's helpful to have a treatment team. We need infusion capacity to deliver these treatments. Radiologists need to be aware of how to monitor, and clinicians need to be aware of how to manage ARIA. Next slide. And the appropriate patient should be selected. So this is for patients with early Alzheimer's, MCI or mild dementia, positive amyloid tests, currently on CSF or PET, but maybe on plasma soon. Careful screening of the baseline MRI to rule out cerebral amyloid angiopathy and significant cerebrovascular disease, ApoE testing. The appropriate use recommendations do not recommend currently treating patients who are on anticoagulation because of the risk of hemorrhage. Antiplatelets are okay. Next slide. And we offer there's really practical guidelines in the appropriate use recommendations for lecanemab, and there will be guidelines for donanemab about exactly how to use these, and especially how to manage for safety. When to stop, when to hold the medicine, when ARIA occurs, when to discontinue the medicine to avoid a serious outcome, et cetera. So I really strongly advise people to look at those if you're going to be using this medicine. Next slide. And finally, a very important interface is for the more serious cases. They're uncommon, but they do occur. ARIA can present as a stroke mimic, and the patient goes to the emergency room and may end up on a stroke pathway getting a thrombolytic, which, if ARIA is the primary etiology, could be devastating. And so it's very important to modify those care pathways so the clinicians know that the patient's on an amyloid-lowering antibody, that it could present as a stroke, and to carefully evaluate whether or not ARIA is the primary etiology and manage it appropriately. This might be my last slide. Next slide. That's it. Thank you.
Well, thank you, Dr. Salloway, for that fascinating presentation. And these new and developing treatments provide a lot of hope for patients with Alzheimer's dementia. We'll now move on to questions from our audience, and many of you already submitted questions when you registered, but if you didn't submit a question, you can still post your questions online in the chat section, and we'll try to get to as many of them as we can. The first question is for Dr. Lopez. Dr. Lopez, how do you manage someone with dementia who has frequent bursts of anger, depression, sadness, laughter, unfiltered thoughts, accusations, unpleasant behavior, and aggression?
Yeah, those symptoms are very common in patients with dementia with Alzheimer's disease: the psychosis, aggression, and agitation. The recommendation is that first you need to treat to use change in behavior. So you can accommodate the patient to the environment, help the patient to understand what's going on. After that, we can start with medication. But the recommendation from the American Psychiatric Association is to try to help the patient modifying behavior.
Dr. Salloway, please take this next one. Apart from immunoantibodies, what other lines of treatment should be explored, and what are some recent promises in this area?
Okay, well, as I said, I think that the amyloid-lowering antibodies are just the beginning, and they offer a sort of a foothold, a molecular foothold, advancing the field. Oscar mentioned earlier about tau is another important protein that builds up in Alzheimer's that contributes to neurodegeneration. I'll just mention a program that's exciting to modify tau is we can give a gene-modifying treatment called an antisense oligonucleotide, which prevents or decreases the amount of that abnormal tau protein from accumulating. And it's early days, but so far the biomarkers show that we are actually lowering the buildup of tau on a PET scan. That's the first time we've really seen that. And hopefully there'll be some clinical benefit to follow. So that's an exciting strategy. And so having a combination, Alzheimer's, there's multifaceted facets to the illness in the brain, and having a number of areas that we can target make the most sense.
Thank you, Dr. Salloway. Dr. Rueben, this next one's for you. The person who asked the question says, I know of an organization that was selected as a guide facilitating organization in Michigan, where I live, but I practice medicine in a different state. How can I inform my patients about this resource opportunity?
You can inform them. They will have to find a local guide participant. The good news, although it won't happen until next spring, is that Medicare is going to directly contact all persons with dementia, generally based on their billing codes, et cetera, and tell them which guide participants are available in their area. And there are several organizations that are actually offering this nationally across state lines, et cetera. The Alzheimer's Association has entered an agreement with an outfit called Ripple, and I think they're going into all 50 states. But if there is a participating organization anywhere near, that shouldn't be a problem.
Great to know. Dr. Lopez, this next question is for you. How do you approach a patient who's in denial about their memory loss and doesn't want treatment, while their family desperately wants them to get the latest treatments to slow this disease?
Well, that is not very, it's not uncommon, and it happens frequently, and it takes a long time to the physician to explain the patient the presence of Alzheimer's disease. The development of these biomarkers that we have now, the amyloid scans, the tau scans that we can do in our patients, that helps to teach the patient what they have. So these biomarkers are very helpful to convince patients that they are in trouble.
Thank you. Dr. Rueben, please take this next one. With the rising number of individuals being diagnosed with memory disorders, is there any plan to implement the guide model in other organizations, such as local level nonprofits?
Yes, that's music to my ears. Thank you. So a couple of things. Number one is that the local community-based organizations can partner with guide participants. And we're seeing a lot of this, and it doesn't have to be already done. It can be something in the future. But if the local community-based organizations can identify a guide participant, they can work out some kind of a partnership. The second, and what we're really pushing for, is to try to get managed care plans to start offering this kind of benefit. And they have the flexibility to do that now. And that's maybe one of the reasons why Guide was confined to fee-for-service. But yeah, so hopefully this is the beginning of a movement, and everybody can get in.
Thank you. Dr. Salloway, please take this next question. Are there assistive technologies for aging that you think might change the landscape for Alzheimer's care?
Well, I think the answer is yes, absolutely. I think we can learn a lot from the personal assistants that we all have. There's all this data being collected on us every day, from our car, from our stove, from our home, from our phone, from you name it. And that can be really informative to clinicians, providers who are caring for patients with dementia or potentially at risk for dementia. So I think there'll be a whole new digital age that will assist clinicians in evaluating patients and make it actually much easier to monitor. I think there'll also be, for example, with ARIA monitoring, there's our software programs based on machine learning that are very good at detecting the signals of ARIA at least as good as to assist a radiologist, but at least as good as the most experienced radiologist. So I think we could take advantage of artificial intelligence type programs for the benefits of patients now.
Okay, stay with me for one more question, Dr. Salloway. Should treatments that target beta amyloid in the brain be taken in if proteins have been found in the person's brain, but the individual does not have a diagnosis of Alzheimer's or mild cognitive impairment?
Okay, that's a great question. And we don't know the answer to that yet, but it's being tested. So both of the medicines, lecanemab and donanemab, are being tested in people who are cognitively unimpaired, but are building up plaques. So they're early on, even earlier in the disease process, because they don't have symptoms yet. And I'm confident that these medicines will lower the plaques in these patients. They're not really patients, in these individuals, just as they did in the patients who already have cognitive impairment. Now we have to see, and it's going to take a while to get that clinical readout, whether or not there's a clinical benefit from removing plaques at an even earlier stage. So the answer to the question right now is no, unless they're in a trial, because we don't know how beneficial it is yet, but we're hopeful that it will be helpful even earlier.
What exciting research you're doing. Dr. Lopez, this one's for you. What are the treatment options for someone who's on aducanumab, given that the drug is being discontinued?
Well, patients, they are offered to go to lecanemab. So there is normally some people they wait about 6 months to go from one drug to the other, but we don't know which one is the right gap. I don't know, maybe Steve knows more about this, but it's something that we don't know very good, but there has to be some gap between ending one treatment and starting the other.
Dr. Salloway, you want to weigh in on that?
No, I agree. There should be a washout. Again, Oscar's right. We've never tested it, so we don't know. So that's why we don't know. The evidence isn't there, but there should be a washout period, at least 3 to 5 half-lives of the drug before they switch to a new drug.
Dr. Rueben, how can we urge primary care providers to seek a more specific diagnosis than just dementia, particularly given that a specific diagnosis can better help patients plan healthcare finances, healthcare, and facilitate care? Dr. Rueben?
I think I was on mute. I think this is a particularly appropriate question because over the next 3 to 5 years, I think that the plasma markers are going to wind up getting approved and might be able to tell people who have Alzheimer's disease versus other dementias. There are also new scans that are available. So right now in 2024, it's really pretty much a clinical diagnosis with some imaging studies, and some are using CSF markers as well to rule in Alzheimer's disease. But in the next 3 to 5 years, I think it's going to be a dramatic change, and this will really help primary care providers.
And Dr. Salloway, a follow-up question to that. Do you think blood biomarker tests for Alzheimer's will be approved in the near future?
Well, I totally agree with David. I think we're on the verge of a revolution, really, with the plasma biomarkers. They're looking very robust, reliable, and I think it's really going to transform how we evaluate. They're not standalone. Clinicians still need to inquire about cognitive impairment, try to determine if it's likely due to Alzheimer's, but then we will have confirmatory tests available in the primary care setting. And that will be super helpful for the treatments that I was talking about today. But also it will be helpful for what the questioner was asking about earlier diagnosis and planning, and just getting them really ahead of catching Alzheimer's way earlier than we're doing it now.
Well, all of this is so exciting. Dr. Rueben, here's a question for you. How can general practitioners help patients and their families build and organize their dementia care support system?
This is hard. It's hard. I provide primary care. I know what that visit is and how crammed it is, et cetera. And I also know that there are a lot of local resources that I just don't have time to ferret out. So here, this is one area where I think guide is a tremendous opportunity for a primary care doc to refer to the local guide program, but still be the primary care doc. So it's kind of like getting additional help. And that's what I would seek. Social workers can also be extremely valuable, some nurse practitioners, but this is what guide is supposed to do. It's supposed to help primary care docs so they can be the quarterback and they can manage the overall care, but they have some help.
Well, as a primary care physician, this guide program sounds fabulous. Dr. Salloway, here's a question for you. Are there new clinical trials offered for people with the family history of dementia?
Yes, those families, there are certain families, about only 1% or less of all Alzheimer's is due to actually a dominant mutation. And there's a special program in the United States and around the world called the Diane study. So if this questioner comes from a family with early onset due to a mutation, they should check out the Diane study, DIAN, and find out if they might be eligible or their family might be eligible. So that's how we know that amyloid and when amyloid and tau changes in the brain, the whole timing came from those families. Because the mutation, we know someone is going to get it, we know the age they're going to get it, and we can start studying them as soon as they become an adult. And so this is where all the biology of all these new biomarkers really have evolved in part from those type of family studies. So that's one type. Another type are people who carry, Oscar talked about ApoE as being the most common risk gene. If people have 2 copies of this risk gene, it's only 2% of the population, but then the chance of Alzheimer's is quite elevated. And so patients who carry ApoE4, especially carry 2 copies of E4, there have been special studies for those, and there will be future studies for those patients. And so that's really important. And again, we can diagnose that early before there's any cognitive impairment.
Well, we've got lots of questions left, but unfortunately, we're out of time for today's session. Many thanks to Drs. Lopez, Rueben, and Salloway for sharing your expertise and your insights. And many thanks to all of you for joining us today and for your great questions. And if you want CME credit for today's discussion, here's what to do. Log into your free AMA EdHub account and click on the Take Quiz button. And if you don't already have an EdHub account, please sign up. It's free. Then take the quiz and claim your CME credit. As we close out today, I want to remind everyone that this was the final webinar in our 3-part series, Navigating Brain Health and Dementia. Recordings of this and previous webinars, along with additional resources, are available on AMA's EdHub. The link's in the chat, and it's also being shown on the screen. Thanks again for joining us, and have a great rest of your day. For the American Medical Association, I'm Dr. Sandra Fryhofer.